Depression is so common in the world that it has been referred to as the common cold of mental illness. Believe it or not, 15% of the people in this country will be treated during their lives at some point for depression. Among those 15%, there will be a number who will attempt suicide. It's something that we should know about, and we're here today to find out more about depression in the first of a two-part series on the subject with Dr. Harvey Stancer, who is a psychiatrist at the Clark Institute of Psychiatry here in Toronto, and with Phyllis Moss, who has undergone treatment for depression herself and made a comeback, which we will talk about. Dr. Stancer, we talk, I understand, about two kinds of depression. What are they?
Well, the two kinds are the normal feeling that we all go through when we're feeling blue or down in the dumps. And just as anxiety is a normal phenomenon when you're studying for exams and so on, so is depressed feeling. The other is something that we call clinical depression, which goes far beyond that, and other symptoms, bodily symptoms, often go along with it.
This is depression that we all, as you say, we all feel blue, we all feel low. When the medical profession gets involved is when the symptoms do not go away.
And when the symptoms are more than just feeling down in the dumps and blue.
What would some of them be?
As I mentioned, they're what we would call bodily or physiological symptoms. They affect appetite. Often the appetite is decreased. Weight goes down because of that. Sleep is a problem, and it's a particular kind of sleep often, although that varies. Sexual interest and appetite goes very early. People complain of having difficulty with their memory. They even have trouble with constipation at times. So a number of such factors. I could mention others, but the person who is feeling down in the dumps or blue doesn't necessarily have all of those symptoms.
What causes it?
Cause is unknown. There are a lot of studies going on throughout the world suggesting that there's a biological or physiological cause. There are substances which exist in all of our brains, which we think probably are not at the right level. And there are also the psychological issues, and we're not sure how much part they play in this, because when we feel blue or down the dumps, we know that this is in response to an affront or having trouble with one's spouse.
Some change in your life that you don't like?
That sort of thing. But that doesn't necessarily have to go along with the clinical depression we see. It may or may not.
Before I ask Phyllis about what happened to her, is it true that people are genetically predisposed to depression, that depression, in a sense, runs in some families?
There's no doubt that it runs in families, just as diabetes or multiple sclerosis does. This suggests genetic relationship, and we and others have actually published on this a few years ago, showing that if you look at some of the blood genetic markers that one can measure, that there seems to be a relationship with those in families who have depression and the members of those same families who do not.
So it could be in your genes, could be brought on by a life change, and there's a good deal about it we don't know, but it makes you feel a whole lot less than human from what you described about the symptoms. Phyllis, in your case, was there something that brought on going into the deep depression that you wound up in?
There were some family problems, but it just came on more or less very slowly. I got the feeling that I couldn't communicate with people, and I felt if I stayed away from people, then I wouldn't get into problems.
So it was a feeling of great anxiety if you were put into challenging situations? And
yes, and I wouldn't communicate with my family. I had a son and a daughter and a husband.
Over what period, Phyllis, did this get worse and worse and worse, as I understand it did?
I would say a 3-month period that I slowly got into. I even had signals with my family. I wouldn't answer the door. I wouldn't answer my telephone.
You were so afraid of strangers?
It wasn't strangers. It was just I was afraid of outside. I didn't know why. Whether I felt I was going to be hurt, whether I felt I would make a fool of myself by talking. I became depressed to the point that I would sit and cry. I didn't know what I was crying about.
So you were in real pain.
Oh, yes.
Did you have any sense of what was happening to you?
Yeah, I had. As you said before, it sometimes occurs in families. And I had problems when I was younger with my mother, and she did the same thing. And even at that, I didn't realize what was happening to me.
How did you decide that you would seek help? Because a lot of people, I think, it takes some courage to go out and admit that they're incapacitated.
Yes, it does. It takes a great deal of courage to say, I'm not helping myself. I need somebody to give me a hand. And I was fortunate. I lived right across from my church, and 2 or 3 times I would call my minister and just talk to him on the phone. I felt that he was one person I could trust. And finally it got to the point I couldn't even talk to him. I would be into the tears.
So did you admit yourself to a hospital, or were you admitted?
I went over to talk to my minister, and he said to get to my own doctor, and I phoned him, and he made me an appointment with a psychiatrist for a Friday afternoon. I went up to see the psychiatrist, and again, I couldn't do anything but sit there and cry.
How long were you in hospital?
I was in for a year, but it was a lengthy progress that for the first 6 months I was confined to the hospital. Then I began to get day passes and weekend passes, and then I got that I could go out.
Let me ask Dr. Stancer. Obviously, you were receiving some treatment, not from Dr. Stancer, but from your own psychiatrist. What do you do when people reach this point where they're immobilized with depression? What are some of the ways in which your profession can deal with it?
Well, it's not an unusual story we've just heard for somebody who's rather seriously depressed. One of the first things one has to consider is whether you put the person in hospital or not. Somebody doesn't always have to go in the hospital to be treated. And the first line of defense, I think, is the family doctor, which we've already heard about. And when necessary, they refer the patient on to a psychiatrist, but not always, because a family doctor can treat depression as well.
On admission to a hospital, what kinds of things can be done?
Well, the kinds of treatment that are available vary all the way from psychotherapy, which is the talking relationship, to medication. The milieu, just bringing a person into a hospital away from the stress of the outside world, often is helpful. And as you know, electroconvulsive therapy is used in some instances as well.
Is it very much an individual thing? Very much you have to follow a patient's personal characteristics and just trial and error kind of thing and cure?
Well, medicine, throughout medicine, whether it's psychiatry or not, is empirical. Medication is used more commonly for the kinds of depression we're talking about than any other thing, and that's been available since the late 1950s.
Let me ask Phyllis, are you cured? Do you feel that you're cured?
Yes.
How is that done?
Through a lot of family work, being aware that if I felt at all distressed, I could pick up the phone and phone the hospital, and they have staff there that
The family support is key, is it not, Dr. Stancer, that you have, or some kind of personal support in addition to medication or other things?
A generalization like that, although it's understandable from a lay point of view, I'd have to say no. It is important at any time, but if medication works, you'll find that the person can get along despite all of the stresses that may be going on in the outside world.
Let me ask you a final question, because we're out of time. Can we deal effectively with depression in virtually every case now?
Not virtually every case. As in every other aspect of medicine, about 2/3 of the cases respond very well to medication that are available, and unfortunately recurrences do occur.
We know that you must seek help if it becomes immobilizing. Thank you both for coming and giving us some insight into the subject today. And we're back in just a moment with some of the incredible story of Colonel Raymond Monroe.